Hello, everyone. This is Lorenzo here. We've had a little bit of technical problems. I think we have addressed them, and we'll be starting very shortly. The first speaker will be Jillian Stikeman, the matriarch's daughter, who will be giving a bit a introduction and welcome from the Stikeman family. Jillian, are you there?
Yes. All right. So welcome, everybody. It's really great to be able to, quote, see you all again. It has been quite a year, and COVID-19 has demanded that we become much more innovative. So I'm really thrilled that we're able to be able to have this virtual gathering of the Stikeman Visiting Professorship. I'm just sorry that I will not be able to meet Yolonda Colson in person, nor be able to catch up with all of you over cocktails. That was always the fun part of the evening. Anyway, this is just an event that has always made an impression on my sister and I, as well as our mother, Shirley. And just for a quick update on my mother, now at 93, her health has started to fail. And after a recent fall, unfortunately, she's now in a long-term care home. But saddest of all is seeing her lose her quick, sharp mind. She had a really incredible mind that half of us could never keep up with. And she's losing that, unfortunately, to dementia. But I know that she would love to be here. And she had always lived an independent life until just recently, which is amazing. I also want to wish congratulations to all the graduating residents and wish you all the best in the next phase of your careers, and hope that you have been inspired and continue to be. As so much has been learned over the years and much more to be learned, as I hope you all will be today with the talk by Dr. Colson. And now I will hand it over to Dr. Ferry.
Thanks so much, Jillian. We'll get all the technical issues kinked. By the end of the day, it's going to be smooth, okay? I promise you. So this is, I just wanted to share a little bit of a background of where we're coming with the Stikeman professorship. This is also, many of you already know, it's been going on for a long period of time. The Stikeman professorship, endowed initially by Shirley and her daughters, this is our 52nd year in the Stikeman professorship in cardiac and thoracic surgery. This is not only the oldest visiting professorship in the Department of Surgery, but it's the oldest continuous visiting professorship in all of McGill, irrespective of ecology, psychiatry, anything, engineering. This is the longest and the continuous running visiting professorship of all time. Dr. Mulder celebrating the 50th, the 50th anniversary of the Stikeman Visiting Professorship. He published a book that was published this past year, highlighting this incredible moment in our academic calendar. As you can see, over the past 51 years, we have really had the who's who, the academic superstars in cardiac, thoracic, and congenital cardiac surgery visit McGill. And this we use this as a springboard to not only increase bi-directional communication, but also for future research endeavors, and more importantly, also for our fellows to reach out into this larger academic community that is cardiac and thoracic surgery throughout the world. Clearly, Shirley, as Jill had mentioned, this is a different year. There's a lot of changes. This is what it should look like. This Stikeman Day, as I mentioned, is really the most important day in our academic year. We celebrate the resident and trainee research that's performed in our respective divisions of cardiac and thoracic and congenital cardiac surgery. We celebrate the graduating residents. Here's Shirley's at her birthday. I think it was a 91st birthday. The last in-person Stikeman that we had 2 years ago with Alec Patterson as our visiting professor. And we also welcome all our residents and fellows, pastoral trainees, and alumni back to McGill So it really is a homecoming for this entire community, and it really is one of the things that I found the most endearing part of my role here is really seeing this our residents and fellows move on and become really world-class leaders elsewhere. Things have changed. Clearly, we're doing this virtually, where we've had to cut it down to half a day in order to prevent Zoom fatigue. But what has not changed? What has not changed is the caliber of the visiting professor. I could say without hesitation that this year's Stikeman Visiting Professorship, Yolonda Colson, is truly an academic superstar in the field of thoracic surgery and thoracic oncology. Dr. Colson initially undertook her MD and PhD training at Mayo as well as Pittsburgh, respectively. After that, she stayed on at Pittsburgh for a general surgery training, during which she did a 4-year postdoctoral research studying transplant immunology. Following this, she went to the Brigham and trained there, and followed and continued on at the Brigham, proceeding through the ranks of assistant, associate, and full professor at the Brigham Memorial Hospital in Boston. In 2019, she was lured across Boston, over Back Bay from Longwood Medical Center to the Massachusetts General Hospital, where she's currently the chief of the Division of Thoracic Surgery and holds the chair, the Hermes Grillo Professor endowed chair in a professorship in surgery, Dr. Grillo, and also her predecessor, Doug Mathieson, were both previous Stikeman Visiting Professorships. This really brings us closed loop. Not only is she the first female or woman chair of the chief of the Division of Thoracic Surgery, but she's also, I believe, the only non-MGH trained the chief of the Division of Thoracic Surgery. Was probably even more impressive than the fact of being the first woman. So Dr. Colson is truly an academic superstar. She's had over 200 publications. And she's a clinical innovator. She has 5 patents. She really is at the forefront of where we think of academic thoracic surgery, and is more than I am completely delighted that we're finally able to listen to her speak. Hopefully we can do it in person in the future, but this will have to do until then. So Dr. Colson, please stand up and take the mic, and we really look forward to listening to you speak.
Well, I want to thank you all so much, because we've talked about this for a long time, and we've really wanted to come, and I am going to come someday on a vacation day and find all of you, and I'm going to talk and tour McGill, because it's been one of those truly legendary places that it's almost magical in its name and quality that I want to come see. I'm hoping that my shared screen is working and everyone can see it okay. And it is a great honor to be here and to be able to share at least some of our research and thoughts with all of you. And I want to say a special thank you to the Stikeman family. It's been nice to at least briefly meet you this morning. And again, these professorships are amazingly important to the medical community and the surgical community. It is what holds the glue to a whole place, and builds new relationships. I want to really kind of dedicate this talk to those patients and mentors that have shaped who we are. And I think that's particularly true for graduating residents, to reflect back the patients that you've seen, the mentors that have made that difference. They will impact you for your entire life. And I think what we're going to see here is that that's exactly what this talk is about and this professorship is about. I want to talk a little bit of what I have been able to at least learn about Richard Allen Stikeman. He was born in Philadelphia in July of 1923 to Dorothea and Harry E.C. Stikeman, who were from Montreal. And his schooling was in Selwyn House University School and eventually the Naval College of Royal Roads, Victoria. He served in the Second World War in the Navy, serving both in the Royal Canadian Navy Volunteer Reserve, and then was in the landing ship infantry for Prince Henry. And it actually was in the Normandy landings on June 6th in the Microdevices sector, which was a red-green sector for Canada on Juno Beach D-Day. And so he was in the Microdevices sector and served there, and then went on to do tours in Italy and Greece. When he came, this is a picture of the ship, which you can imagine, this doesn't look all that big, and it probably wasn't a lot of fun going over to Normandy. And these were classic in that era, and this is what the ships look like. And here you can see, I think this is actually a training exercise that I could find, but you can see where this is one of the assault landing crafts leaving the actual Prince Henry. And you can see that they're not that big. They're small, they're cramped, and the servicemen in that era and World War II, we forget, it's been a while, but it was an impressive time and impressive people. He won multiple naval awards, the 1939 45 Star, Italian Star, the Great France and Germany Star, Atlantic Bar, it goes on and on. He did served quite well. And when he came back, he went to McGill University and got a degree in commerce, and then eventually headed into my town and came down to Harvard University and got his master's of business administration. And this led him to a career at Peacock Brothers, as I understand it. And feel free to correct me at the end with any facts, I'd love to learn them. And he rose up to the level of vice president and general manager. And as Jill has already talked about, he had his wife is Shirley. I'm glad that she is at least still well. I'm sorry about that. As you get older, I have an aunt the same age that we're having the same discussions, and 3 children, Jill, James, and Victoria. In 1964, he started to have some intermittent left chest pain. And as is classic, the chest x-ray was absolutely normal at the beginning of the year, but it persists. And there was a small pleural effusion that was noted in April. And what ended up happening was he had an exploration to try to determine the source of this effusion. And he was found to have diffuse malignant mesothelioma. Impressively, he had a pleural pneumonectomy, which I'll talk a little bit about in a second, where the tumor was removed and actually was able to return to sailing and part-time work. But as is classic in this disease, he had a recurrence in December and eventually died in August of 1965. Mesothelioma is a very rare disease. It's about 0.3% of cancers. And from the numbers that I could find, about 500 Canadians per year get this disease. That's not very many people. And that has ramifications in how much we know about it, how much we can do in randomized trials. It impacts our ability to treat this disease. It's classically in men over 65 years old, more so than women, at a ratio of about 80 to 20. And the number one risk factor is asbestos exposure. The fibers enter the airway and they can reach the mesothelium along the pleura, and you have the visceral and parietal pleura, and the tumor itself creeps down this pleura, and it goes into the fissures and it can go around, and eventually it will grow and compresses and encases the whole lung. Interestingly, about a third of mesothelioma patients are veterans, especially in the Navy. And as was shown in Mr. Stikeman's case, the average life expectancy after the diagnosis of the disease is roughly 12 to 22 months. The reason that the Navy veterans have an increased rate of mesothelioma is that probably because related to the fact that they had a higher rate of asbestos exposure. And it occurs in a variety of ways. One, the direct exposure. In that era, asbestos was used as a fire retardant on the ships, covering nearly every system, boilers, pipes, electrical. They slept and ate downstairs below deck, obviously. And so they were in enclosed spaces without ventilation. And in the shipyards and repairs, they got exposed during these repairs. And so this disease is classically seen in people in the Navy, in the military. So an extrapleural pneumonectomy, you can see the disease here as it's encased the lung and inside the fissures. This is a nice picture from David Rice. And it goes along the diaphragm all the way around the chest wall. And when you do an extrapleural pneumonectomy, you end up taking out the diaphragm, part of the pericardium, You have to take the whole lining, and the lung is what is involved in order to get all around the tumor. And then usually we do a reconstruction where we will do a Gore-Tex patch, which you have to put little holes in, or else you end up with fluid inside and you end up with tamponade, or and we reconstruct the diaphragm. There's been a lot of discussion about prolonging survival and how do we know that that helps and what it is. But we know that the epithelial subtype of mesothelioma does better, is much more likely to have a better resection. The margins are still often positive, but particularly that's a problem in the mixed subtypes. But with selection in trimodality therapy, there's been a variety of studies that have published out where the average survival is 23 to 33 months, but still only about 4% of patients ever make 10-year survival, despite all sorts of chemotherapy, radiation therapy, and aggressive surgery. And unfortunately, nearly all of them die from recurrent disease. So some people have discussed doing pleurectomies and decortication, and we do that as well as a surgical alternative, leaving the lung in place, but it doesn't address the recurrent disease part. And that's what I really want to think a little bit about in today's talk. And this is a classic example of where surgeons and thinking about diseases that we see and how do we prevent local recurrence, because that's what we want to fight. That's what's important to us, because that's what we see every day in the office, right? So one of the questions that I had was about, can we prevent local recurrence? And I had this conversation actually with Sugar Baker when I was either a new attending or just a graduating fellow. And we started to talk about local recurrence and lung cancer and the ramifications of that. And I learned something about mentoring in the sense of at least once a day, let your imagination get in the way, think of ideas that seem out of the box, and then encourage someone to try something new. Because he certainly could have shut me down. And instead, when I came up with some of these ideas, he said, yeah, why don't you do that? Why don't you try that? If it fails, it fails. If it doesn't, then we've got something new. So I think that's important for us to remember. And if you think about the surgical treatment of lung cancer and mesothelioma, the idea is that complete resection yields the best survival. Although lobectomy is a standard of care in lung cancer, poor lung function can prevent that, and we end up doing wedge resections. But we know there's a much higher increased risk of local recurrence with a wedge. And even with a pneumonectomy in mesothelioma, you get recurrence. And survival is limited by local recurrence, lymph node metastases in the case of lung cancer, or distant metastases. So how can we actually address these problems? And we're going to talk about some of the ideas we've been working with over time. And one of the ideas that came out of the discussion was, could we do innovative drug delivery strategies to start to prevent local regional recurrence in some of the diseases that we see? And what I particularly was interested in looking at was, is it possible to prevent local recurrence at the surgical margins? Could we prevent recurrence of these diffuse tumors like mesothelioma? And could we prevent lymph node metastases? And so our first thought, and what came out of that OR conversation, was, could we do drug-eluting polymer films? The idea was, could we put films that have this drug-eluting polymer here in yellow at the top, and I incorporated it with another polymer and a way to hold it all together as a scaffold. And could we actually put that on a site of a surgical resection? And in fact, we've been working to design it so it actually gets incorporated at the time of the resection. Could you incorporate it at the place where you divide? And the idea is, by directing it and regulating the rate at which you release your drug, could you release drug into the surrounding margin and it kill off these residual microscopic tumor cells? And could we make a strong, flexible polymer platform and control the release of drugs? So not too fast, so that we don't have, not too fast so that we end up with problems with healing, but delay it enough to release it then when we want to do so. And what we found, we started out with, could we even release drug and what did it do? And it was quite interesting, because if you look at this diagram here, in blue are the films, and paclitaxel done systemically at the same doses, we end up with a lot of paclitaxel in the blood right initially, and then it goes away very quickly. You only get a bolus effect, but you get very little in the actual tissues itself. You get a little bit maybe at the beginning, but at 10 days, you actually don't have much left. Whereas when we put the films in, what we found is we were anywhere between 10 to 100 times more drug was actually in the tissue, in the tumor tissue at the time. And it lasted, here, this experiment is 10 days. We've now gone out to 30, 40 days. And we continue to have high level chemotherapy delivered at the site of where the tumor was. And what we found was, even if you think about when we normally give drug, it usually goes through and it's cleared out in about 4 hours or so, is about what before you get clearance. And so when we looked at what normal drug doses of paclitaxel were and looked at the exposure for 4 hours versus what we were now delivering was thousands of nanomolar concentrations, we had a much larger increase in the G2M arrest of tumor cells, even though the exposure time is the same. And so the idea is they're all exposed to paclitaxel, but these extremely high doses you can't give systemically. So we don't know what happens with those higher doses. And so when we did that, we found out that fewer tumor cells can actually enter mitosis, fewer of them can actually escape. And it may be that by delivering higher doses, we can actually get better effective results. And so in our small animal studies, we actually grew primary tumors here and resected them. And we knew that when we did that, we could then either implant a film at the place or give them drug. And what you see is that with local delivery of the same amount of drug or systemically after resection, all of those tumors come back within a month in this model. But when we did the films, we found out that essentially the majority did not. Somewhere around 80% or so went on for long term. And we've now altered the film, done different types of constructs, and are getting where we're not getting recurrences at all over time in these models. And so it's really looking at how can we keep increasing the drug, how can we double load it, how can we get short-term releases and long-term releases. And so the concept of now being able to try to address some of these local recurrences in things like sarcomas and lung cancers are becoming really important. So one of the things you find is a simple journey takes you kind of unexpected places sometimes. You may not be where you thought you were going. I was doing research in tolerance and transplantation, and here I am now in drug delivery after a simple conversation in the OR. And so this has led us to other kind of avenues of looking at things. And so this polymer chemist that I work with, Mark Grindstaff, is who helped us start with the films. And we have been long-term collaborators ever since. And it's been one of those serendipitous collaborations that turn into your life's work, right? So the other project that we started to look at was expansile nanoparticles, and I'll explain what those are. And essentially, we have these particles that you can see in green. We've loaded with drug that's labeled in green so we could figure out where the drug was going. And you can see it packed inside the tumor cells where the cell walls are red, but the nuclei are blue. And you can see that it's just packed inside. And so what we found was that we could make these little particles, and they get taken up by the endosome, by the tumor cells, and they preferentially are getting taken up by the tumor cells. And we're doing studies to try to figure out why the tumor cell takes them up so much more than normal cells. If we designed these particularly so that if the pH was normal at 7.4, like while it's migrating out, why it's going somewhere, they would stay and not release their drug. However, once they get inside the tumor cell endosome, it's acidified. So the tumor cell, when it gets into the pH of 5, that nanoparticle that's in that endosome will start, we have built in bonds that get cleaved so that then the particle can start to swell, and it takes on water, and it starts to release the drug, but it releases it from within the tumor cell only when we've gotten into that acidified state. That's important because we want to make sure that the drug is only releasing where we want it. We don't want it releasing really fast. We don't want it releasing immediately before it gets to its target. And so we looked at this as a way to try to target. And one of the things that we found was that the endosomal pH allowed us to slow the release. So other types of nanoparticles will have a rapid release, and they'll release very quickly within a few hours. And then you've kind of plateaued your release because you've released it all here. And that's fine if it's already at the tumor and in the tumor. It's not ideal if in fact it's not there yet or hasn't gotten taken inside the tumor, and it takes time to do that. If the nanoparticles at a pH is 7.4, they don't release. So if they're not inside the tumor, they will just sit there and wait. Once they get inside the tumor, however, what we can see is that we get this slow release of drug over time. Now, what's also interesting is if we took these same particles and in essence, didn't allow them to cleave, didn't allow them to be expansile. So we basically blocked that cleavage. What we saw was these guys dumped the drug just like the other particles. And so we have the ability to now start modulating when, where, and how we can start delivering drugs. And that's been pretty interesting for us to try to think about from a surgical perspective, where do we really want things? And here's an example of how these expansile nanoparticles kind of localize to the sites of tumor. So when we look at that, this is a bioluminescent imaging showing an animal where the tumor is actually based at. And when we're looking at where this tumor is, we took the same particles that I showed you and I labeled them with a fluorescent marker so we could see where they were at. And it's quite interesting because we built it into them. And you can see how it basically gets taken up inside the tumor cells, but not the normal tissues. And this has some ramifications because it allows us to think about the possibility that we could use these by taking these labeled nanoparticles and putting them in contact with the tumor, that it may allow us to start to fluorescently guide tumor resection of very small amounts. So this is mesothelioma. And so the ability that maybe we could do a better resection by getting tumors that we don't normally see or appreciate. Along with that is the idea that we thought, well, what about the drug and getting drug to these tumors, not just using it as a marker to see where the tumor is. And so an interesting thing, we know we can put tumor inside of the particles, but we also found an interesting phenomenon, which was that expansion. And when we see the expansion of the actual particles, that motion seems to be able to set up dynamics such that we can pull drug into the tumor as well. So here's an example of we put in particles that had no drug in them, and they home to the tumor as we saw. But when we added paclitaxel drug, what we saw was the drug got pulled into the particles inside the tumor and then was subsequently released over time. And here you can see, here's the tumor sites that we can see that are here. There's unloaded nanoparticles in them, but when we added the drug, you can see, because it's labeled green, it pulls the drug and concentrates it inside the tumor. Whereas if we just added the drug at the same time without the particles, it goes through and gets cleared and washed out. And so we haven't actually concentrated in the tumor sites in these animals. And so when you look at the chart, you can see, if you look at a normal type of particle that doesn't expand and doesn't have these qualities, or you look at saline with the paclitaxel, we get low levels within the tumor. Whereas here we've increased the amount of drug that's inside the tumor because it gets pulled in, which was a quite unexpected phenomenon.
I'm going home. I wasn't for that.
What
It's
we
good.
noticed,
Bye-bye. See you.
what we noticed was that the paclitaxel nanoparticles.
Yes, that's why we thought first thing in the morning we talked with you.
Mesothelioma. And when we
So
look,
you are busy.
All right.
when we looked
Okay.
at the mesothelioma,
Where would you want us to be?
Can I have all
Jane,
the people put on their
This is what I
their
thought, but
mute?
if you have any
No,
other,
no, I think that's great.
because I thought, I don't know, it's rare enough, like it's
Dr.
well known,
Pinescu,
but
can you
it's
please
rare
put
enough
on
that-
mute?
and so when we look here, we can see we took mesothelioma tumor cells. These are human tumor cells that are put inside of mice. And we put them in the belly because it's one of the other mesothelioma models that we use, but it's easy for us to monitor. And when we put them inside, we can see, here you can see how well they grow. They love to grow in the belly. And then what we did is we injected either drugs or different types of nanoparticles afterwards to see if we could impact the growth of the mesothelioma tumor cells. And you can see the tumor grows quite aggressively in the tumor alone, or if we have these nanoparticles but no drug, or even if we have the same amount of drug, IP, and then other types of particles. If they don't expand, they're not as effective. but if they do expand, they're quite effective in terms of looking at of preventing tumor mass. And when you look at it, this is the normal fat of the omentum in the mouse, but there's no tumor. And so we continue to do that. We've done many more of these animals now. And we actually tried to look to say, well, yes, but people don't show up and say, I don't have meso yet, or I just got it yesterday. Can you prevent it? So we looked at animals that actually had established tumor. So we got it started. They had tumor already started. And then we gave them injections of this on a weekly basis of the nanoparticles or drug. And what you see here is you can see if you have just the particles alone won't do it. The drug does have some effect. And then here is when we do these particles. Now, paclitaxel is not a normal treatment for mesothelioma. We don't get high enough levels, it's not used. And yet what is interesting is because these nanoparticles are delivering at such high levels, we're starting to see some efficacy, and it may just be that you can never get enough drug into the tumor. And if you look at survival here, what you see is that the tumors grow or are not slowed down if you have just your normal controls, or if you deliver the same amount of drug in different fashions, you just don't get it as concentrated. Versus here, I think it gets incorporated, delivered inside the tumors at high doses. We've now moved this on to a lung model, which is, I have to thank the people in my lab for figuring out how to do little tiny cytoreductive lung surgeries of mesothelioma in the pleura. But they would essentially do pleural mesothelioma implants in the lungs, and then would do thoracotomies and remove that section of the lung and try to keep the mouse alive. And then would at the time put in some of the intrathoracic, and they ended up with the survival of roughly doubling it by the time you think about essentially surgery and adjuvant local chemo. So it was just the idea if we could even do that at all. So these are these areas where you try to challenge yourself, right? You want to look and say, let's know your strengths and your weaknesses. This sign says, I make it to the fence in 2.8 seconds, can you? So it's important to see if you can make yourself run a little bit faster sometimes. And so we wanted to know, okay, this is local recurrence. Can we think about preventing local regional recurrence? And one of the first things I wanted to look at was lymph nodes, but I had to find a way to figure out what were the lymph nodes that were at risk. And so we started in patients looking at near infrared imaging. And what we did is we utilized a way that we could go down the airway and in the bronchoscope, put in indocyanine green. It's mixed in a way to try to slow down its migration by using albumin. We think that helps. And you could mark where the lung lesion is here. But what we found was that it would migrate back up the lymphatics and tends to identify where the lymph node is. Now we're still working out the methods. It doesn't work every time. There's two lymphatic systems to the lung, one along the pleura and one along the bronchus. And so I think that makes this probably one of the harder systems to do. But you can see here in a diagram showing, if we look at this localization, this is actually a clinical study where we found this little ground glass opacity. We wanted to mark where that was. And we went down by navigational bronchoscopy and drove out to that area and actually put a little bit of this indocyanine green out at that level so we could mark where that lesion was. And we do it by fluoroscopically guiding that. You can see this migration across the lymphatics on the surface. So this would be the pleural lymphatics. But you can see there's this blush right here. So it was kind of where the level 5 was. And when we opened it up, we could see that there were these two lymph nodes. The third one back here isn't colored, right? It's not green. So not all of the lymph nodes necessarily drain the same tumor site. And so it's interesting for us to start to learn and understand what are these lymph nodes and what do they mean? And could we identify which ones are most likely to have tumor in them? What was interesting is that when we started to look at those, we know that in lung cancer, in stage 1 lung cancer, some of the patients will recur and develop nodal metastases. And so when we looked at these, we looked and determined that whenever the sentinel lymph node, when I took it out that was green and made them look at it pathology, If it was negative for histology and had no tumor, when I looked at the whole rest of the lymphadenectomy, I've not found other cells, other lymph nodes that had tumor cells in them. So it seems to be predictive of the status of the lymph nodes of that patient. What was interesting is 7 of the patients, we did have a positive sentinel lymph node, and several of them had other nodes in the specimen, which were also positive. But we had 4 patients of which the only node that was positive was the sentinel node, and sometimes that was microscopic disease. That had, and our question was, does this have ramifications? So when we looked at patients in which were a contemporary control group, where we did not identify the near infrared, they were all similar patients, they were enrolled in the trial at the same time, but maybe we were still escalating our dose, we didn't have it right, there was a problem with the camera, for whatever reason, we did not identify a sentinel node. We had a pretty classic recurrence rate over time, what our survival was of those patients for stage 1 and stage 1 lung cancer over time. And this is a 10-year follow-up to really look at what happens to them. What's interesting is in those who we had a sentinel lymph node that was identified that was negative for nodal disease, they are all alive and have not had recurrence, suggesting that maybe we're just missing these patients that have nodal disease in stage 1 lung cancer. What is also interesting is that if we look at those who had node positive disease over time, that group had died. Those that was identified as being positive, we do have some survivors, and it may be because those 4 patients who were identified with a single positive node were treated. What I want to know though is, can I go from here, if I could treat these patients that had a single node that was positive, could I actually convert those to basically behaving like negative disease? So it started the question of, is there a way for me to prevent patients who have occult nodal disease from developing recurrence? And so this is where you start to think about your priorities in life. And this picture says, hundreds of years from now, it will not matter what my bank account was, the sort of house I lived in, or the kind of car I drove. But the world may be different because I did something so bafflingly crazy that my ruins become a tourist attraction. So this is my crazy idea. And it came from the idea that when we look at the delivery of chemotherapy into nodes, it's not very good, actually. We end up with chemotherapy. This is a trial where they took breast cancer patients, and half of the group got intravenous chemotherapy and then went to surgical resection. At 12 hours, they took a group of patients. If they injected the chemotherapy around the tumor cell, however, and took those patients, they then measured drug levels within the lymph nodes. And they found that if they gave the drug intravenously and then went to the OR, they didn't actually end up finding much chemotherapy in the draining lymph nodes. But when they looked at when they gave it around the tumor, they actually did have drainage and accumulation of drug within the lymph nodes. So it got me thinking, was there a way for me to better deliver drug from tumor to lymph nodes based on the data that we had before? And so the idea was, could we actually target drug delivery to those tumor-associated nodes by actually using the particles to get into the lymph nodes and deliver drug? And so by injecting around the tumor, we wanted to see if we could get the particles to migrate down the lymph nodes to where we wanted them to go. And here is a large animal study where we injected these particles that we've labeled and making them carry a green dye so we can see where they go. And we injected it way lateral to the breast. And these are, it's migrating the pathway, and it works really well. You can see the migratory pathways in the subcutaneous tissues and in skin. It's very hard to see it. It's harder to see it in the lung. And we could get it all the way up. And so it told us, one, you never know where the draining lymph node is, as one, but we could also look at the draining lymph node and see that in fact our particles got there because we could image it and show that it was green. And in this case, it could actually even migrate up to 40 centimeters. It takes time, so you need to figure out the delay, but it did get there. So then we wanted to know where else would that work? And here is a bowel. You can see it's injected here. You don't really, the particles don't have, are not so labeled that you can see them directly, but then we could do by fluorescence, and we did the merged image where we have pseudo coloration. You can see where it was injected, and you can see it migrate down to the lymph node. Now, what's interesting is it accumulates very specifically within the lymph node. So we set up an animal experiment where you grew a primary tumor and injected these particles around it to see if we could identify, could we deliver drug and could we get it where we wanted it to go? And then we evaluated those regional lymph nodes. And here you can see a lymph node where you can see there's an enormous amount of particles that get accumulated within the lymph node. And these are all labeled in red so that you can see them. What's also important is we then took these lymph nodes and looked at the level of drug that was accumulating. And if we, instead of injecting particles around the tumor, had just injected the same amount of drug, we end up with a low level of drug that actually gets to the lymph nodes. However, when we did it, the same amount of drug by particles, it gets inside the lymph node, and we got much higher on average levels of drug delivered to the lymph node. And what was also interesting is when we looked at this, it seems to accumulate first in the sinusoids, which is often where metastases go. What was really mattered to us, though, was what did it do to the metastatic potential lymph node metastases of these tumors. And here we see that the model is set up so that if you have no treatment, essentially all of the animals have lymph node metastases. If you give them systemic doses repeatedly, we can decrease it a little bit, but eventually they tend to get lymph node metastases. But if we deliver it locally, it doesn't last long enough and it goes through, whereas we had a 60% decrease in the number of, in the lymph node metastases rate with a single dose of particles delivering drug to the lymph nodes. And we're now looking at models of repeated dosing and lung metastases models. So one of the questions is, can we choose drugs better? Maybe paclitaxel isn't the right drug. What's the right drug to do? What would we like to deliver? Where do we need to deliver it? And what we've really looked at and tried to figure out is thinking of ways that we can think about doing in vivo testing of drug combinations and then use that tumor to decide what type of particles. The vision would be that you could figure this out, figure out what to do, and you could take a selection of whatever film you want off. We've now started to do films in large animal models to show toxicity, that we can look at them at 60 days, that we've delivered drug where we want it without toxicity of the wound healing. And it would be nice for us to say, oh, this tumor should have drug X, and you could pull a film off in the OR and implant that type of film to prevent recurrence. And so working with Oliver Jonas here at Brigham and Harvard, he's actually devised these little tiny microdevices, and it can put in about 20 different things. You can see how small they are. Here's a penny. And inside of it, he actually creates these. So he tests 20 different drugs or combinations packed within these little wells, and it gets put inside the tumor. And then you can look at the response around the microdevice when it's removed. And you can look at what the efficacy is, and you can look at all these different 20 combinations, and you can look for drug synergism, and you can do that without any systemic drug exposure, because it's only 1/1,000,000th of the systemic dose is in each drug. And so we're working on ways of doing that and figuring out how to put that into patients with lung tumors and harvest it in a fashion that helps us. So the idea would be we can maybe figure out what that is. I bring all this together to show we win little battles that help the war, but clearly we have to do better, and we want to figure out ways that, sure, we can do these resections, but we want to make it so that he can stay sailing. And so the local release of chemotherapy by polymers can prevent tumor recurrence and growth. We think that the paclitaxels, these particular ones, seem to be able to target established tumor. We're looking at how they get in. The endocytotic mechanisms are quite interesting. The lymphatic pathways may allow us to start specifically targeting these tumor draining lymph nodes. And the efficacy of how well these work with the same amount of drug may just be because we're actually delivering the drug where we need it with less systemic impact. Sometimes surprises change the outcomes. These are my two daughters when they were younger. And we are all role models of our own, and we have whoever you meet, patients you meet, whoever you mentor, you have impact on them. And so one day at dinner, I was a chief resident in the old days where you often weren't home for days at a time. And my one daughter made the comment at dinner, like at 9:30, 10 o'clock at night. She said, "Mom, the neighbors across the street are really strange." And I sat for a while and I realized, one, I didn't know what she meant by strange. And two, I actually didn't know who the neighbors were and had never seen them. So I didn't really know what to expect. And so we kind of asked her, "Well, you were over there today?" She says, "Yes." And we said, "So what was strange?" And her answer was, "The mom seems to cook dinner every day, and I think the dad is a doctor." And we realized that that was strange to her, but we told her that there were families like that, and she had to be open-minded, and that seemed to be okay. So they have gone on to have a very different perspective of the world and what's normal. And as we bring home particles and all sorts of things, you will influence those around you as well. I want to say thank you both to all those in my lab who really help keep us with new ideas and do the hard work. Dr. Grindstaff and the people in his lab. It's a very unique opportunity. We have joint lab meetings where we have all the PhDs and the surgeons, and we learn from each other because we have very different worlds. And I want to thank all those at MGH. They have been fabulous. I could not have asked for a more welcoming pandemic response. So they have been really quite good in reaching out and helping us make that transition, and have been really terrific in meeting the agenda we need to do. I want to leave you with one of my favorite poems, I guess you would call it, and it's about finding purpose. And I think it's quite fitting for graduation. "The purpose of life is to be useful, to be responsible, to be honorable, and to be compassionate. And I think this is particularly the second half. It's above all to matter, to count, to stand for something, to have made a difference. And I think this professorship and the Stikeman family has truly made a difference. Look at all the list of people that you have introduced to the McGill community. And I think you have made a profound difference in how we think about our field. And I want to thank you very much for that. Thank you.
Wow, what an outstanding, incredible lecture, Yolanda. It really is. You've really taken us on a journey of scientific discovery. You've thrown in personal tidbits there. You have done more investigation into the Stikeman Vision Professorship than I think it looked like, even though you said you haven't received Dr. Mulder's book, it looks like you've read it cover to cover, because it really, I'm just blown away by the talk. It really was well crafted. And what's remarkable is how you've taken a sort of clinically relevant questions that matter to our patients and us, and breaking them down, taking them to the lab and look at things from a different perspective in a very innovative manner. Really remarkable. So I will open this to a few for questions. I'll ask you guys to raise your hands. You don't need to put it on the chat, but you can just raise your hand and I'll call on you. Or if I don't call on you in a certain amount of time, then go ahead and open your mic and speak. I see John Cools.
Dr. Colson, thank you that was an amazing talk. Pretty close to my heart. I'm sort of the resident with the interest in mesothelioma, and in fact, I applaud you for actually getting these intrapleural therapies to look like they started working. I think that mesothelioma is particularly suited to local therapies. I had one question for you. We've had a lot of difficulty here translating mesothelioma into clinical models. And in particular, with the advent of patient-derived organoids and patient-derived xenografts, I was wondering if you've had any luck developing models using patient-derived tumor samples. And my second question is, you've been doing a lot of work testing chemotherapy, which is fantastic. Have you had any luck modeling immunotherapeutic approaches, which have, sort of gained more traction in the past few years?
So I think most of my work has just been in working at how to get it delivered and into the cells and to do that. I know having done this transition in the pandemic and all has made it a little harder for us because there was a big, no one could do anything for a while, like they shut all the labs and things down. So, Brigham has a very active research in that, looking at the immunotherapies, and they have a whole kind of mesothelioma kind of research program over there. And so that's going to get, they've been doing some stuff, which I haven't had the chance to reconnect recently with it, but I know we were growing and trying to look at ways of getting tumors to grow and to implant them. They're hard to get them to grow, surprisingly enough. And I think one of the things that I've learned over time, clearly, I think the pleural effusions are a much better resource for you to try to grow organoids and to do things like that. At least in my hands, when I've tried to do the solid tumors, there's so much non-tumor stuff in there that by the time you get it, process it, chop it up, try to get it out, they just don't seem to have the same ability to take or to grow or to propagate, at least in my hands. And I don't know if that's true with others, but I think the concept of doing the effusions and trying to make organoids out of that seems to me would be more successful with that. But you're absolutely right in the sense of we don't have many patients overall. It's not as, but it's not as big of a disease. A lot of times people don't actually recognize what it is for a long time. And then on top of that, it's hard to get models to work. And so it makes it an incredibly difficult disease to treat and to do. So I think one of the things that we've been talking about is I think these organizations that really look at bringing whole groups of people together, this is one of those diseases where I think it is that everyone has to work because everyone has some patients. And how do we figure out what to do that? And so I think figuring out how to collaborate around that is good, right? Is that kind of what you found in your hands?
Well, we've had a lot of trouble. Every time we have a mesothelioma patient come in, I've tried to establish some patient-derived organoids for the purpose of drug testing, really, because as you know, this is a very frustrating disease to treat. They recur, and there's not really much you can. And we've had very limited luck with that. We've had marginally better luck with PDXs, but marginal is a generous term.
No, I know. I tried to do a bunch of PDXs for a long time, and I think it's the tumor chunks don't grow well. Right? Maybe this new microdevice will make us be able to put them inside tumor and test for drug sensitivity in vivo.
That would be a fantastic way.
We haven't tried that yet.
Amazing.
Are there any other questions? If not, I have a question. What's remarkable is like all the cellular therapies and the bioengineered cellular therapies really require an antigen to target. So you have to identify what targets you're going after. But it looks like your nanoparticles are able to deliver this payload without knowing what the antigen is. How do you think that's happening? That's remarkable. How is it?
I know we're as stunned as you are. So in some of it has to do. I found this article, and we're now breaking down each of the pathways that the tumor cells have some alterations and some increase in their endocytosis and their uptake mechanisms, far more so than normal cells do. And so we're actually going through looking at all the different pathways for endocytosis and blocking them. And we're figuring out where the particles aren't getting in and when they do get in. And there's very specific pathways that these particles seem to be using. And our next comparison is to see, as we look at normal cells, are those pathways not as active? Is it that we've just preferentially targeted some pathways that are used? The challenge to that is trying to grow and propagate normal cells is hard. So it takes a long time. Like if you transfect them, then they're not exactly the same. So we've been working on comparing that. And it seems to be probably the macropinocytosis pathway is particularly, these particles seem to like that the best. And I think they are upregulated in cancer cells.
Yeah, outstanding. John, you have a question? Spicer?
Yeah, Dr. Colson, this is a really amazing talk. I'll echo everyone else's comments so far. It's a brilliant journey you've brought us on. I was particularly intrigued by those microdevices that your team has developed. Is your vision that these would be delivered by endoscopic techniques? And as you know, one of the limitations, I suppose, of neoadjuvant therapies, immunotherapies in particular, is ingress of appropriate cells to affect a tumoral response. And often we'll see a pileup of CD8 positive T cells sort of at the periphery, but not always penetrating right into the deep tumor microenvironment. So just curious if you foresee this being deliverable by endoscopic or IR guided techniques, and could it be a way of improving immune cell infiltration?
So currently the microdevices have so little drug in them. They're not treating as much as they're looking for screening. And we've done it mostly percutaneously or transtumoral. They're small enough that you could probably drive out on an av bronch and insert them. The challenge we have right now is we're looking at ways of retrieving them, finding in the tumor without cutting them. There's a whole bunch of logistical things that are tricky. It's easy when it was done in breast. He did a very nice study in breast because he could just core it back out and you're on the outside, but you can't go into the patient, core it out and come back and say, we'll figure out what drug to give you later, right? So there's a whole bunch of logistics of doing it, but it is interesting when they looked at it, they could see which drugs work better in the tumor. So our ability to, ideally, what you'd like to do is be able to put it in there and then retrieve it at the time to be able to determine what it is. The argument about how do we get penetration better, maybe not so much that these devices would deliver large payloads, but it may be that it helps us choose better what would be the right drug. And then can we get infiltration better with things like the nanoparticles or some other way that we cross across the normal cells and get into those. And that's what I think we're going to end up doing, but it's probably percutaneously. Okay. There's a couple questions in the chat I wanted to at least make sure I answer. One was the idea that these particles and these different delivery things, we are looking at both intra-abdominal as well as in the chest. And sometimes it's easier. So our large animal studies looking at the films and looking for toxicity has been done intraperitoneally because we're looking at it for sarcomas and retroperitoneal sarcomas. And so it's easier sometimes to do that. So we're looking for basically both cavities. I think one of the reasons that this has maybe been more successful than we thought is by thinking of it from a surgical perspective, which is something I think is really good for the residents. If you first start to look at all the literature on nanoparticles, everybody injects it IV and tries to get it to home to the tumor. And so it's the thought of systemic delivery, but it goes to the spleen and the liver. If you think about it as a surgeon, what we see every day is the actual tumor site. We see where we want to go. So we don't always have to think about following everybody who doesn't see what we see. So if you put it, you can put it in the bloodstream, but if you're right there, just put it where you want it. And so one of the elements is thinking about if we're in the cavities, we could put the drug and put the treatment we want there. So it's a little bit of a surgical bent on thinking about what we see and how we could treat our patients. The other question in here is about growing mesothelial cells in the matrices other than Matrigel. We've tried a bunch of different things, and I'm sure Jonathan has too, about the different ways of growing. I almost think it's that there's so much fibrotic tissue within the mesothelioma that it's hard to get stuff into it or get the cells out of it. It's like this big giant fibrotic mass that has some tumor cells in it. That's my take on when I look at it.
Well, I think this is outstanding. Thank you so much, Dr. Colson. It's we've learned so much from this talk, as we all have. It really was a journey. I think an incredible talk that you put together. I will ask all the attendees to fill out the validation form. This should be available on, I guess, somewhere on the website or somewhere, or even emailed. I'm not sure. Emma will help you out with that. I would like to move on to the research presentations. The next moderator is Renzo Ciceri, the chair of cardiac surgery.
Yes, good morning, everybody. Good morning, Dr. Colson. Welcome to McGill. I also want to thank you for this remarkable presentation that you offered us this morning. Remarkable for its contents, but also for its clarity. So thank you very much for maintaining the high standard of the Stikeman Professorship legacy. So we'll move right into the research presentations then, if you're okay. I welcome as many participants as possible to remain on the link. We'll move right into our first presentation, which is titled "The Targeting CXCR2 Mediated Neutrophil Recruitment to Non-Small Cell Lung Cancer," given by Mr. Simon Miette.
Not doctor yet.
Won't be long.
All right, thank you very much. I'm Simon. I'm a third-year PhD student in the lab of Jonathan Spicer at McGill University, and I'd like to thank the organizing committee for giving me this opportunity to share my latest findings about the role of CXCR2 in mediating neutrophil recruitment to non-small cell lung cancer. So my research focuses on lung malignancies, which account for about 14% of all newly diagnosed cancer cases in Canada, and about nearly 1/3 of all cancer-related deaths. Fortunately, recent therapeutic progress utilizing immunotherapy has dramatically improved the oncological outcomes of lung cancer patients, indicating that the tumor immune microenvironment plays a critical role in regulating disease progression. However, because the response of patients are really heterogeneous, there is a clear need to characterize host factors that compromise this anti-tumor immune response. Studies have shown that neutrophils, the first responders of the innate immune system, represent the major immune component in the microenvironment of lung tumors and play a major role in promoting lung tumor expansion, mainly by suppressing anti-tumor immune surveillance. So cancer cells can recruit these neutrophils to escape anti-tumor immunity by secreting various chemokines, including CXCR2 ligands, as shown here, such as CXCL1 through 8, which are really important to mediate neutrophil egress from the bone marrow. In a recent meta-analysis of immunotherapy trials, including 2 nivolumab trials in non-small cell lung cancer, as shown here, the Milero group in Spain has shown that patients with high serum levels of IL-8, a CXCR2 ligand, and potent neutrophil attractant have significantly worse probability of survival, as shown here with the red line. However, it remains unknown whether CXCR2 can be targeted to prevent neutrophil mobilization or activation in the microenvironment. So our hypothesis is that neutrophil mobilization to and their retention within the lungs is mediated by CXCR2. And we also propose that neutrophil infiltration supports the formation of a tumor-promoting immune microenvironment, and that interfering with CXCR2 will blunt non-small cell lung cancer progression and increase the response to immune-based treatments. So first, to confirm that presence of neutrophils is detrimental in patients, we histologically examined lung cancer samples that we obtained from the clinic and stained for neutrophil markers. And we found that patients with higher levels of neutrophil infiltration, as shown here with the red and black lines, have a markedly worse survival compared to patients with low neutrophil frequencies, as shown here with the green line. Then, to determine the clinical relevance of CXCR2, we performed a genomic profiling of lung adenocarcinoma tumors using publicly available RNA-seq datasets from Stanford's PRECOG dataset, and we found that high expression of all known CXCR2 ligands, including those shown on the screen right here, were significantly associated with worse outcomes compared to tumors with low expression of these genes here, as shown with the blue lines on the Kaplan-Meier graphs. So together, these results suggest that neutrophil infiltration and neutrophil recruiting chemokines are associated with adverse outcomes in lung cancer patients. Next, we asked if we could impair neutrophil trafficking towards cancer cells by blocking CXCR2 ligands. So to accurately track neutrophil migration patterns, we use silicone microfluidic devices that separate neutrophils from cancer cells. So when the cancer cells are present in the side chambers as shown here, neutrophil can migrate towards them when they are loaded in the central channel. So we took a human lung adenocarcinoma cell line called A549 and we stably knocked down two neutrophil chemokines that were associated with L1, and we seeded them in the device. When compared to wild type or control tumor cells, we found a significant reduction in neutrophil recruitment from the central channel, as shown by here as a decrease in the number of these red cells that are neutrophils. Similarly, when we pre-treated the cancer cells with antibodies targeting either CXCL1 or MIF, we observed a marked decrease in neutrophil migration. So together, these findings indicated that in vitro blockade of CXCR2 ligands could significantly inhibit neutrophil trafficking. To determine whether genetic targeting of neutrophil chemokines could reduce tumor outgrowth in the lungs, we used an orthotopic model of murine lung adenocarcinoma in which the tumor cells are directly injected in the thoracic cavity in the left lung. We used this model to compare wild type to CXCL1 deficient lung cancer cells. Here we observed that loss of CXCL1 expression in cancer cells significantly reduced tumor expansion in the lungs. Histological analyses are ongoing to determine whether this reduction in tumor burden is associated with reduced neutrophil trafficking. One factor contributing to the high mortality of lung cancer is metastatic dissemination. So to explore whether CXCL1 deficiency in lung tumors could slow down hepatic metastasis, we intrasplenically injected wild type or CXCL1 deficient lung cancer cells, which directly traveled through the bloodstream to the liver to form metastases. So using this model, we observed that genetic targeting of CXCL1 again could prevent dissemination of lung cancer into the liver, as shown here with these H&E stained liver sections. To determine whether reduced liver metastasis was associated with impaired neutrophil trafficking, we analyzed neutrophil recruitment deficient tumor cells, and you can see here that neutrophil migration to tumor sites, as shown in green, was greatly reduced, which was consistent with our in vitro findings. As an orthogonal approach, we tested whether pharmacological blockade of CXCR2 could reduce disease progression. So we used the CXCR2 inhibitor called AZD5069, which has already been shown to improve the conditions of patients with asthma and significantly extend the survival of mice in preclinical trials of pancreatic cancer liver metastasis, as you can see here with the pink line. So we started a trial using the experimental liver metastasis model in mice that we treated bidaily with AZD5069. At endpoint, we found that CXCR2 inhibitor was markedly effective at reducing tumor dissemination, therefore showing a great translational potential in this disease setting. So in summary, these results suggested that targeting CXCR2 or its ligands could blunt primary lung cancer expansion and liver metastasis and associate with reduced neutrophil trafficking to the liver. Now, interestingly, in a recent report by the Hidalgo group in Spain, this mechanism of CXCR2-mediated neutrophil recruitment to sites of inflammation was shown to be tightly controlled by the circadian rhythm and the major circadian protein regulator, ARNTL. So to determine the clinical relevance of this circadian clock protein in lung cancer, we searched the TCGA RNA-seq data sets, and we found that ARNTL2 was very significantly associated with poor survival. So given the known role of the circadian clock in driving neutrophil migration patterns, we wanted to determine whether circadian oscillations in immune cell mobilization occurred in our orthotopic model of lung cancer. So we injected mice with lung adenocarcinoma tumors, monitored them for 14 days, and utilized them at different time of day to collect tissues. So while little circadian fluctuation in immune cell trafficking could be observed in tumor-free mice, as shown here with the gray line, we found significant oscillations in tumor-bearing mice, as indicated here with the red line. So we found, for instance, that accumulation of CD8 T cells in the blood was 15-fold higher during the night than during the day. Conversely, peripheral neutrophil accumulation was 11-fold higher during the day than during the night. So these results suggested that lung adenocarcinoma cells may co-opt mechanisms of circadian rhythmicity to mobilize immune cells. We also performed various functional assays to find out whether neutrophils are phenotypically distinct. We performed a neutrophil extracellular trap formation assay and found that their propensity for activation varied greatly depending on time of day. And finally, we looked at bone marrow leukocytes and found that granulopoiesis, or expansion of diverse immature neutrophil progenitors, was markedly higher at night in tumor-bearing mice. So future experiments will determine whether this is due to a time of day dependent production of CXCR2 ligands by tumor cells. So together, these results suggested that circadian rhythm may be an integral regulator of neutrophil trafficking and a master controller of the anti-tumor immune response in general. So in summary, we saw that neutrophil infiltration and the neutrophil recruiting chemokines are associated with adverse outcomes in lung cancer patients. We found that the blockade of CXCR2 ligands in vitro could significantly prevent neutrophil mobility. We found that genetic targeting of CXCR2 ligands could significantly slow down primary lung cancer progression and metastasis to the liver. We found that pharmacological blockade of CXCR2 can reduce metastatic expansion of lung tumors in the liver. And finally, we saw that circadian rhythm could be a very important regulator of neutrophil trafficking and the response to lung cancer. So on that, I'd like to thank you for your attention and thank my wonderful research team, including my supervisor, Dr. Jonathan Spicer, as well as Megan, Ronnie, France, and Caroline at the RIMUHC, and Daniela Quayle's lab at the Goodman Cancer Center. Thank you.
Good, fantastic lecture. Thank you very much, Simon. This is really outstanding work. Are there any questions or comments for Simon? Yes, go ahead, Dr. Colson.
Okay. That was fantastic. I think it's a really interesting area of research, and I know we've recently started working with McGill. I don't know if you've seen some of his work, and Ralph Wiesleiter in this idea of the neutrophils and different classes of neutrophils, as you talk about. What do you think the impact of this circadian rhythm may be? It seems to me there would be potential for when we treat patients or chemotherapy administration or all sorts of different ideas. Have you thought about that? Or?
Yeah, that's exactly what we want to know. Actually, we started a few preclinical trials using this AZD drug in the orthotopic model of lung cancer. However, the results were not really significant. And we were wondering if it was because we were not giving the drug at the right time, because if we're giving the drug with the neutrophils are very low, maybe that's why we're not observing any effect. So there is a really interesting opportunity for us to synchronize the administration of our immunotherapy drugs with the circadian rhythm. And I think that is also relevant for many types of immune cells. So we're targeting neutrophils, but it may also be true relevant for T cell immunotherapy. But because these neutrophils have such a short lifetime, this is why we're more interested in this cell type.
Very good.
Excellent. Anything else for Simon? Great. Good work, Simon. Our next presenter is Dr. Daniel Su with a talk titled Neutrophil Extracellular Traps Promotes Lymph Node Metastasis. Daniel?
The host stopped my video sharing. Hello, can I have the access to my camera? Okay, thank you. Hello, good morning, everyone. My name is Daniel, and I'm a PhD student with Dr. Ferry and Dr. Kuz. And today I'll be talking about my research on neutrophil extracellular traps promotes lymph node metastasis. So this project focus on lymph node metastasis. They are the first sites of the metastasis for most of the solid tumor. And for thoracic cancer, such as esophageal cancer and lung cancer, 20 to 30% of the newly diagnosed cases are with lymph node metastasis. So it's very important to study this kind of disease, which is ubiquitous, which is treatable, but it's before the lethal and systemic metastasis. So talking about lymph node, they're an immune organ. They're made of various kind of immune cells, predominantly lymphocyte, but as well as neutrophils. They're the research interest of our lab. So naturally, they are the antigen representing cell and they're antibacterial cells in the lymph node. However, as more and more people are reporting that neutrophil has a pro-tumor function, it is also reported that the increased neutrophil lymph node infiltration is associated with a poor outcome in gastric cancer patient. However, the cellular mechanism, the detailed mechanism is unknown. So a very important hallmark of the neutrophil activation is the release of neutrophil extracellular traps, also known as NETs. They are a mesh-like structure which physiologically capture the bacteria and kill them. However, our lab was the first to find that the NETs can capture tumor cell as well, nutrient their growth, thus promoting metastasis. Could the release of neutrophil extracellular traps be involved in lymph node metastasis as well? And more importantly, neutrophil extracellular traps, they're very vulnerable to several kind of chemicals. So could this be a treatment target of lymph node metastasis as well? With this kind of research question, we first start with a tumor microarray. They're made of 175 patients with gastroesophageal adenocarcinoma. We specifically look at their lymph nodes, both with and without cancer, and we stain for neutrophils and NETs. So we found that an increased neutrophil in the lymph node in the patient with lymph node metastasis compared to N0 patients. But notably, what is interesting is in the patient with lymph node metastasis, they have negative lymph nodes without tumor, but in this kind of negative lymph nodes, there's also an elevated neutrophil level compared to the N0 patient. And we also stain for NETs. As you can see in the red channel, this is neutrophil and the green channel is NETs. They exist in the context of the lymph node. We have different background of mice and we inject them with different kind of tumor. We sacrifice them at an early time point or a late time point and study the tumor draining lymph node. First, we absorb the same phenotype in a mouse tumor draining lymph node. As you can see from the representative images here, the red and the white color nets, they're surrounding the green GFP positive cancer cells. And we also try to quantify the neutrophil recruitment and the NET deposition by time. What is interesting is we found tumor progression is associated with neutrophil recruitment and NET deposition. As tumor progress, the higher the level of neutrophil and NETs will be present in the lymph node. But what is most important is that this process happened before the overt metastasis development. This is to say this phenotype happens in a pre-metastatic manner. As you can see the represent image here, the red and white color nets, they're already present in the lymph node before the green color tumor cells arrive to the lymph node. And we specifically try with two different kind of tumor cell, which is a lung cancer and a melanoma, to prove that it's a universal biology of cancer. It's not subject to the cell type. So this is the dynamic of the NETs deposition, but what is the consequence? And most importantly, can we intervene this kind of NETs deposition? So first, we start with the transgenic mice. It's a PET4 knockout mice. These kind of mice, they're unable to release the NETs. So as we can see, the knockout results in a depletion of NETs and a significant decreased level of the tumor cell burden in the lymph node. And again, this is double confirmed by quantification. As you can see, decreased level of neutrophil, decreased level of NETs, and a dramatic decreased level of the tumor cells in the lymph node. But also we want to try the potential of a drug treatment. There is a chemical called neutrophil elastase inhibitor. It's a small molecule, safe, oral available, and is under clinical trials for many indications. This kind of chemical, they can prevent the release of the NETs. So after giving the mice neutrophil elastase inhibitor, we found the same trend, a decreased level of NETs, a decreased level of neutrophil recruitment, and a decreased level of tumor, lymph node tumor burden. Again, this is double confirmed by quantification. So at last, I would like to conclude my talk with the significance of this work. First, in human, we found that nodal NETs deposition is associated with poor survival in gastroesophageal cancer patients. Second, in the mouse model, we found that nodal neutrophil recruitment and the NETs formation, they precede overt nodal metastasis. And NETs appear to facilitate nodal metastatic development, but they're very vulnerable to pharmacological inhibition, which abrogates this process. Thank you. And any questions?
Thank you very much, Daniel. It was an outstanding presentation. Any questions for Daniel?
Daniel, you know, lymph node metastases are near and dear to my heart. This is fascinating to me. And it's interesting because you saw that the prognosis was worse in high NET, see if I have this right, on negative lymph nodes.
Yes.
So why do you think that is? Is that just because we don't see the tumor cells there yet? Or why do you think if the lymph nodes are negative, they still do worse?
Yeah, because these negative lymph nodes, they're from lymph node metastasis positive patients too. They might.
Oh, I see. Mm-hmm.
It might not be immersed with the tumor cell, but the change is already happening there. As we cannot draw the conclusion from human sample, but if the same thing happens, same trend happens in the mice, it's a pre-metastatic process. So this lymph node, they're already been prepared.
Yeah, they have the pre-metastatic niche.
Yes.
It'd be interesting to look at them with our sentinel lymph nodes.
Yes.
Like are they not prepared yet? Like if we could really look at the sentinel node, could we see if they're prepared as an indicator?
Yeah.
That's an interesting idea. I don't want to dominate the questions, leave it for somebody else, but that's fabulous.
Thank you.
It sounds like there's an opportunity for collaboration there, Daniel. Maybe you should talk to Dr.
I have samples, so we could lay out a plan. Absolutely.
Sure. Thank you.
Any other questions or comments for Daniel? Great, fantastic. Let's move on then. So our next speaker is Ida Derish with a presentation titled Generation of Patient-Specific Stem Cell-Derived Cardiomyocytes for Disease Modeling and Pharmacological Testing, the Heart in a Dish study. Go ahead, Ida.
So hi, everyone. Thank you so much for having me, for giving me this opportunity to speak today. I'm Ida Derish. I'm a PhD candidate in Dr. Chicheri's lab. And I'll be discussing the generation of patient-specific stem cell-derived cardiomyocytes for diseased modeling and pharmacological testing, which is entitled the Heart in a Dish study. So I'll first discuss the research context of this work, proceeding to methods, some exciting preliminary data, as well as a timeline for our study. So starting with some background, we all know and we're intimately aware of how heart failure is a leading cardiomyopathy and actually constitutes a leading cause of mortality and morbidity worldwide. And despite the fact that the standard of care has increased over the past few decades, there is unfortunately a limited efficacy of drugs for heart failure and other chronic cardiac illnesses. And it's still very difficult to treat these conditions effectively and in the long term. There's also a very poor prediction of what drug works for what type of patient. And on top of that, the administered drugs have some undesirable side effects more often than not, which in turn lowers patient compliance and actually reduces the drug effectiveness in the general population. And this is actually a very prevalent problem. And it's in part because during clinical trials, they're very costly, and the diversity of the patient population is not really accounted for, and conclusions are drawn from a homogeneous sample. So all of these obstacles in developing proper cardiovascular disease therapies are in part because of the fact that current models of heart failure and other cardiomyopathies have limited clinical applicability, unfortunately. So the real challenge here is, how do we personalize these medical therapies for heart failure patients? How do we do that? So ideally, we would have a sample of patient cardiomyocytes, which are cardiac cells, on which we can test the responses of various drugs. And right now, currently, there's mainly two options when it comes to these cells. So the first are from heart biopsies, which you can imagine are very invasive for the patient, and they're inefficient because the cardiomyocytes that are collected are actually terminally differentiated, which means that they actually don't proliferate in culture. So it would be really impossible to perform a repeatable, streamlined, and high throughput drug testing. And the second option is to use immortalized cell lines, which are derived from very few patients and have been passaged, so they really don't represent patient diversity, unfortunately. So just to recap, these cells might highlight cardiotoxic effects of some drugs, but most of the patient-specific reactions would be completely missed by these cardiac models, and it doesn't really offer much value as a personalized screening tool for drug testing. Now, in 2006, a lot of the limitations that I've just mentioned were resolved with the arrival of induced pluripotent stem cells. And these cells essentially are achieved by taking somatic cells and reprogramming them. And then once we have an iPSC population, we can modulate pathways and different factors that have been described in the literature in order to achieve essentially any cell of our body. So this really offers a wonderful opportunity and a non-invasive method to obtain cardiac cells from patients for testing purposes or for disease modeling. And I'm really happy to say that since starting the Heart in a Dish study, our laboratory has actually optimized our iPSC generation protocol for our iPSC biobank, which makes it more efficient, more rapid, less costly, and it provides cardiomyocytes that are more suitable essentially for drug testing. And I won't belabor the point too much, but I think this slide really summarizes everything that I've said so far. And I hope you can appreciate how this Heart in a Dish study actually builds a repository of patient samples, which can be useful in this vast array of spheres. And before we move on to the really interesting data that we've collected, I'll quickly walk you through the process of our Heart in a Dish study. So first we receive blood from the patient and we proceed to isolate a specific subset of cells, which we then reprogram via electroporation. And then you can see in this image right here, the population of stem cells is shown in a kind of sea of fibroblast looking cells. So we have to actually ensure that they're pure. Once we do passage them multiple times, we have a pure iPSC population that is ready to be differentiated into patient-specific cardiomyocytes. And just a very quick aside, this is something that's very important in iPSC generation, is to how to assess the purity of our cells. Well, we actually do something that is the golden standard for most commercialized iPSC cell lines. So we actually stain them for pluripotent stem cell markers for every single line that we generate. So for the Heart in a Dish study, we actually have established to date a biorepository bank that currently holds 77 blood-derived patient samples. We have 3 lines from patients for cardiomyopathies for iPSCs that we actually have generated into cardiac lines, and 2 iPSC cell lines from healthy donors, one of which is cardiomyocyte form as well. And onto the really exciting stuff. So here's the video of one of our iPSC cardiomyocyte lines. And I'm happy to say that essentially in all of the lines that we've generated, we actually have this kind of characteristic beating, albeit to different degrees. And you can kind of tell that the beating actually progresses from the bottom up. So there is some kind of synchrony in our cultures. And now, if we compare the contractility amplitude between the different cultures, we can actually see here that we have completely different patterns. And I think this graph on the right here really demonstrates that very nicely, because essentially it shows that depending on the 3 different cultures that we look at, the amplitudes and the speeds are completely different. And if we look at a more general overview of beating speed, and this was actually extrapolated from the data from all the videos that we took, we see that each patient has a very different average beats per minute as well. And I'd like to specify that these are, of course, preliminary results, but it already points to the fact that there's this great diversity that arises, and that there is a lot of value that will come from studying these patient-derived cardiac cell populations. And I'm not going to belabor the point too much. I'd love to answer some questions, but since getting this study off the ground in June 2020, we've actually progressed really, really well. Our goal is to achieve 100 patient samples in our biobank by the end of the year, and to generate iPSC-CM lines as well to begin our preliminary characterization studies, and then move on to our disease modeling and testing different kinds of drugs to see the different reactions between patients. And one of the aims of my PhD is actually to generate a trilineage cardiac organoid as a model, as well as a tool for pharmacological testing. And if you have any questions about that, I'd be happy to discuss the applicability of that during the Q&A. And finally, I hope you enjoyed my talk, and I'd like to say a huge thank you to my supervisor, Dr. Renzo Ciceri, who's the principal investigator in our myocardial regeneration lab, which is actually located at the Research Institute at the MUHC. And we have so much access to essentially a bunch of platforms that will help us in this project moving forward. And my wonderful lab mates, Jeremy Zweig and Kashif Khan. And I'm very happy to say that this project is actually expanding and will be welcoming more students into our lab starting next week to study these patient-specific differences more closely. So yeah, and I have no disclosures. I'd like to say a huge thanks to the Courtois Cardiovascular Signature Program for funding us. And I will take any questions that you might have.
Ida, thank you very much for that presentation. Very clear and concise. Any questions for Ida?
Are there, you have some that are normal patients without cardiomyopathies and some aren't. I know you don't have many, but do you see that there is a difference, not just in the maybe extent, but that seems like there would be timing and rigor and how much the contractility is? Do you see a difference from cardiomyopathy patients to the other in the limited sample that you have, or not so much?
Yeah, so it was actually very interesting, because when we started generating the iPSC samples, so they were still at the stem cell stage, there was actually a big difference between the two healthy donors that we've generated and the cardiomyopathy patients, because they were actually much slower at getting generated into that stem cell state, which was very interesting. And then in the when we started moving on to cardiomyocytes, the same thing happened, and we can actually see a huge difference in the pattern, in the amplitude of contractility, and whatnot. So yeah, absolutely.
It's very cool to watch them contract.
Yeah,
that was very cool.
Bottom and the reactions.
Can I ask a question? How have you compared? I know you don't have that many patients, but do you have actually myocardial biopsies of these patients, and how are these iPSCs correlate phenotypically and characteristically to the primary? Can I tell you, for someone who does a lot of organoid work, every reviewer that I've ever sent anything to, they always want to ask the same thing: how does it compare to the freaking primary tumor? So have you done that yet?
So we haven't done it yet, but we actually started collecting the samples. So one of our patients, we have collected from a heart transplant essentially, and we plan to kind of collect these samples as we go. And it would be very interesting to perform this kind of study essentially at the RNA level to see whether the expression is different at the protein level and also at the morphological level, because of course, in the end, we want to generate a model that does make sense and that does convince people. So definitely that is in the works.
It's terrific.
Great, thank you very much, Ida. Well, everyone, I want to thank you for your attention so far this morning. We've come to a break point in our session. So why don't we take 15 minutes or so and we'll reconvene at the same link. I also want to give a warm welcome to our alumni, which I haven't had a chance to mention yet this morning. So it's great to see so many McGill graduates come and join us for this virtual Stikeman. So thank you very much for being with us. We'll see you shortly then. Thank you.
So we're starting at 9:30. Is that right, Renzo?
Well, it looks like 9:20. Let's say 9:20, Lorenzo.
4 minutes.
Is that it?
It's okay. We can do that.
Well, I didn't realize what time it was. So I'll be honest with you. I was looking at the agenda. Let's say, let's say 9:30.
Okay, 9:30. Okay, Feister, you're on next. Okay, buddy.
Got it.
Great. Thank you.